So good evening, everyone. Welcome to this webinar. As I see, we have a few people still joining. We ask you to bear with us. We begin in the next 1 minute. Thank you. So good evening yet again. Thank you for taking time to join us this evening or morning, depending on the part of the world you are in. Welcome to this webinar by the Kenya Medical Association on medical fraud, understanding medical fraud, so hosted by the Managed Healthcare Committee of the Kenya Medical Association. My name is Dennis Okaka, a member of the Managed Healthcare Committee under KMA. And today we'll have a number of interesting speakers with us. I hope you'll be able to gain and challenge them and ask the tough questions about this topic. As part of pre-discussion, you are invited to introduce yourself to each other in the chat. So the chat, I hope it's open so that then people can introduce each other. Otherwise, then please put in questions in the Q&A section. And that's pretty important, just to ensure that then we are able to track the questions afterwards. Whatever is put in the Q&A is trackable. What is put in the chat is not. So ensure you put your questions in the Q&A. Yes, in the absence of that, I'd like to thank our partners, the Kenya Healthcare Federation. So the Kenya Healthcare Federation are our formal partners for this event, and they are the private sector wing of Kenya Private Sector Association and representative of private healthcare providers across the country. So I'd like to thank them for partnering with us. KMA is also a member of KHF as a professional association. So thank you to KHF for partnering with us in this session. We'll have a quick 1 hour webinar. So we will start with Dr. Elizabeth Gitau, who will give us a short presentation, 15 minutes. And she'll speak to medical fraud from her perspective. So she'll introduce herself, and I'm sure she's no stranger to many of you, having worn the KMA hat severally before and still wearing it indirectly. So she'll introduce herself, and then she will speak to medical fraud from her perspective as a healthcare provider. Please. Are you with us? Hello. I hope she's not having network issues. In case she is, then we can always move to the second speaker. And so our next speaker would be Mr. Jack Njuguna. Jack Njuguna represents one of our insurance providers, and he'll introduce himself and he will speak to healthcare fraud from the insurance perspective. Jack, the stage is yours.
Okay, thank you, Dr. Ari, and good evening, everyone. As you've heard, Jack Njuguna is my name. I'm the Regional Head of Forensic and IT Security at Jubilee Insurance. I've been in this business of investigations for the last almost 16 years, and actually the last 9 years I've been doing forensic investigations within the industry and outside the industry. So I'm happy to be here this evening to share some of the insights that we have seen from the insurance industry. I'll be doing a very short presentation because we have roughly about 15 minutes that have been given. Just a short presentation to set the stage for us, define what fraud is, how does it look like, and if time allows, I'll show you a few of the case studies that we have been able to witness from our end. So I think, Dr. Okaka, that should be fine. I can share my screen.
Please go ahead.
Thank you. So I hope you can see my screen in presentation mode. If you
yes, it's there in full screen.
Okay.
So you can see it.
Okay.
Okay.
Yeah. So due to time, I will rush through some of these slides, but when time allows, any other time, I'll be happy to go into the details. First is a general definition of fraud. What does fraud mean in its general terms? And we say one is that it is an intentional deception. So at the end of the day, when somebody decides to commit fraud, what we say is that there has to be an intention to commit that particular fraud. And at the end of the day, there has to be a gain. The perpetrator who is committing that particular fraud has to have a gain. And in this case, in most cases, it will be a financial gain. And there has to be a victim. Now, depending with where the fraud is being committed, then the victim will vary, and we'll see shortly what that means. Now, there are 4 elements of fraud that we say must be there for us to say that fraud has actually occurred. One is that somebody has to make a material false statement. And in the case of health insurance, for example, or healthcare fraud, you'll find that the material misstatement could be something, for example, a misrepresentation of the diagnosis. Could be impersonation, where somebody wants to get medical services that they are not entitled to. The person who is perpetrating the fraud has to have the knowledge of that particular fraud that they want to commit. And in most of the cases, it's very intentional. It's done knowingly. But in some certain circumstances, we have seen where somebody has been reckless. And in my experience and what we have seen, we normally say that there is nothing like a perfect fraud. Something has to be missed. And that's how, in most cases, fraud becomes discovered. Then for us to again say fraud has taken place, there has to be reliance on that material false statement. In this case, for example, if diagnosis or misdiagnosis has been done, or there is falsification of the claim form, and then the insurance company is made to believe that that is the correct document, then they rely on that correct document to make some payment, then we'll say fraud has occurred. And then finally, as I say, there has to be a victim. In the broader sense of it, then you can say fraud can encompass anything that uses deception as its principal technique. Now, let's go to healthcare fraud. What does it mean? I'll give you 2 definitions. One is that it's either an individual or a group of individuals or a company or a provider in this case, who again knowingly misrepresents or misstates something about the type, the scope, the nature of the medical treatment for them to be able to either get what we'll call unauthorized payments or to gain financially from this misrepresentation. The other definition that I'll give you is that it's the knowing and the willful execution or the attempts to execute either a scheme, to deceive a fraud healthcare plan. In this case, for example, if you think in our case, something like NHIF, an individual, a group of individuals can come together and they decide or putting together a scheme that is purposely designed for it to be able to benefit from the program that we have. Now, having defined that, the next question would be, why do people commit fraud? I'll quickly go through what we call a fraud diamond. For us to say that fraud has occurred, or for somebody to be sufficiently motivated to commit fraud, then we have 4 parameters that are important. Number one is that there has to be pressure or incentive. And in this case, there could be, for example, a target. You've been given a target. Let's say, for example, in your workplace, you've been given a target to have a certain number of disbursements. Let's say it's medication or number of patients that you've seen. So for you to be able to hit that target, you're put under pressure, and therefore you will, for you to hit those particular targets, you will have sufficient motivation to either do something that is not correct or something that is likely to be a misrepresentation. 2, there has to be a rationalization. One of the things that I have heard is, especially with providers, for example, you'll hear somebody saying, but the insurance companies are not paying us on time, but the insurance company have not remitted funds, and so on and so forth. So somebody justifies their action today based on the experience that they have with providers. Then there has to be the opportunity. The opportunity will come to you because, for example, in where you're sitting, you're privileged, you're seeing patients, or you're privileged, you're the one who is issuing a particular report. So you get that particular opportunity simply because of the nature of the job that you do. And then finally, we say you must have the capability to do it. In some cases, we say, for example, if you're in charge of a process, you know the process inside out, and therefore you have the capacity or the capability to commit fraud. When all those 4 parameters come in place, and you're sufficiently motivated, chances of you committing fraud are very, very high. In fact, I'll conclude by saying, when greed overcomes fear, then fraud will prevail. Then the question is, who commits this fraud? Are they the people in this webinar today? Or how does a fraudster look like? How can we pick a fraudster from the crowd? The Association of Certified Fraud Examiners came up with a few parameters, which we'll quickly go through to try and define how does this person look like, the person who is likely to commit fraud. They went ahead to subdivide this between men and women, and they came up with common characteristics. I will not go through all of them, but you'll find that if you look at any given population, you look at the female population and why they commit fraud and how they commit it. And then you look at the male population, why they commit fraud and how they do it, then you'll find there are a bit of differences here and there. But at the end of the day, they also share some common traits. So for example, if I just mention 1 or 2, you'll find that most people who are likely to commit fraud will be between the age of 31 to 45. And it's for very simple reasons that between that age, 31 to 45, 1, you're looking for financial independence. 2, you're comparing yourself with your peers and you're wondering, why am I not doing as well as my peers are doing? If you're a man, unfortunately, for example, you'll go home and maybe, your wife can ask you, what kind of a man are you? Why are you not like so-and-so who is driving a big car? If you're a lady, again, it's about financial difficulties. It's about, the kind of life that you want. And all these things, when they come in together, collectively studied, then the Association of Fraud Examiners came together and they said, once these characteristics or traits are observed and given the earlier fraud diamond that I showed you, then it is likely that this is how a fraudster looks like. Now, this is important because if you are running, for example, your own facility, then it is important to get to understand the kind of people that that you're working with. I will briefly touch on executive fraud. I may not have sufficient time to go through this, but executive fraud is basically fraud that will be perpetrated by the owners of the business. And in most cases, this is very, very complicated fraud. It is higher than the normal fraud that you know about. It takes much longer to execute. And I've shown 4 different schemes that we have seen over the years. And this has also been confirmed by the fraud survey that is done on an annual basis by the Association of Fraud Examiners. In our case, and you can see billing schemes, contribute to up to 33% of all the total frauds that was observed from what we'll call the executive category, who in this particular case are business owners. Now, in summary, I would say we don't have a homogeneous way of describing who a fraudster is, but we know one common factor, which is motivation. That if you are sufficiently motivated to commit fraud, and remember the fraud diamond, then it is very likely that you will commit that particular fraud. So I'll not go into all that. In terms of fraud controls, allow me not to go into it. Let me just quickly talk about cost of fraud, because at the end of the day, once fraud is perpetrated, fraud has its own victims. It's not a victimless crime, so to say. Each year, whether it is the provider, whether it is the insurance company, whether it is the person who is paying premiums, there is a cost to fraud. If you listen generally in Kenya, they will say the cost of medical insurance is high. If you go to the providers, they will tell you you're not making sufficient money. If you go to the insurance companies, most of them are in losses. So there is a victim. It's just a question of who. And again, we say, who are these people who are committing this fraud? It's either medical providers, it's either patient, and it could be any other categories. I will quickly touch on the 5 elements in terms of the cost of fraud. One is business impact, bankruptcy. I'm sure you all know companies that have closed down because of bankruptcy or because of fraud, which led to bankruptcy. We can all mention that. We can mention the Tuskies, the Nakumats, the Chase banks, the Imperial banks, the Resolution Health, Blue Shield, and so on and so forth. All of them, the common element is that there was fraud. And because of that fraud, there was business impact, which led to the closure. There will be a human impact, which is basically loss of job, loss of savings, loss of retirement benefits. There is a reputational impact, especially if a particular category is viewed to be a fraudulent group in the society. And I will not go into the details. I'm sure if I was to ask all of you to mention a group that is viewed as fraudulent, you would have an answer for me. But there is a reputation. And these reputational impacts will affect both you and me, depending on whether we work in that particular industry or not. And that ties together in the industry impact. There are people today, I'm sure you've heard, for example, people will come and say, insurance companies are not paying claims. And when you speak to somebody in the insurance company, they will tell you, but the doctors are exaggerating their costs. And if you speak to somebody else, they will say, but the lab technicians are asking, or the tests that I'm sent to are exaggerated, and so on and so forth. So there is always a perception. And this affects you and me from a reputation perspective. Then lastly, there is the question around regulatory or compliance impact. We've all read of fines and penalties that have been issued because of non-compliance. And in most cases where there is non-compliance, then fraud comes in. Those are just a few headlines that I will not go into the details, but just goes to show you that this fraud that we are talking about today has victims, and these victims could be you, could be me today, could be somebody else tomorrow, but at the end of the day, we've got a victim. I'm happy to say, as I was preparing for this, I came across a statement that was issued by Kenya Medical Association on 20th of June 2023, touching again on the issue around fraud. This followed the NHIF scandals that we've all read in the media. And you see, as an industry, you are being impacted. You're being impacted because somebody somewhere has done something that we would call deceitful for purposes of financial gain. So I will not go into this, but as an industry, you can see that this topic of today has an impact on all of us. Again, just quickly, in terms of an impact of fraud, this again is a media article. You can Google, I have given a link down there, where one of the underwriters went ahead to say, we are not going to allow treatment using branded drugs. And somebody issued an official statement on that, and they say, as long as you're covered by us, you're going to use generic medication. You've also seen the underwriters, for example, who have stopped doing medical insurance at all. Why? Is because most of them have been making losses for a number of years, and they have made a strategic decision that we no longer want to do medical insurance. So I'll not go into that. In terms of what are we doing, I've just given a few headlines of what we are doing as an industry, as a company. We do take matters fraud seriously. You can see some of the headlines. The headlines that you see here, these are some of the cases that we've taken to court. The case that you see there of 1.9, the gentleman is still with us in court. He's actually a medical doctor. The other case there you see of 11 charged, I think around 7 of them have been in jail for the last 5 years or so, and some of the cases are still going on. Some of these headlines that you see here, some of them we've decided to do an out-of-court settlement. Others we have had to debar some of these providers where providers are involved and so on and so forth. So I'll not go into that. But I'll summarize. I think this will be my last slide. I'll summarize by just to mention a few of the key thematic fraud schemes that we have observed and seen from an insurance perspective. One is that we have seen services being billed for that were not given to clients. And to be more specific, I have seen, for example, within the dentist category, you will find that quite a bit of billing that goes in there, in as much as we will try and put measures, for example, pre-authorization and so on. You'll find that there is quite a bit of billing for things that were not done. How do we capture this? When we speak to the clients, as either when we're doing follow-up, just to find out how are you treated, was the service done in good time, and so on and so forth. Then you'll ask a client, you had a root canal, and the client will say yes or no. Did you have an impacted tooth? Yes or no. And you tend to pick some things that were billed that's really, were never offered to the client. There is the second item there, which we are calling billing separately or invoice splitting. This has become elevated, especially in the last 1 or 2 years. What has been happening is that in an effort to control costs or to manage costs, some insurance companies have gone into what we call fixed cost pricing. And what has happened is that once we agree on a fixed cost, then what we are seeing is either one, providers have found a way of splitting an invoice. So you'll find, for example, if we have agreed the fixed cost is 4,000, you'll find an invoice for consultation of 3,000 or 2,000, an invoice for lab for 3,000, an invoice for prescription at 2,500. Now, all this ideally should be billed together, but somebody has found a clever way of splitting them over a period of 1 or 2 days. In some cases, we see them in the same day. In some cases, we see a patient being sent from one branch to the next branch of the same provider. On one side, you are sent for consultation and let's say lab, then you're sent for prescription on the other side to try and beat the system around fixed prices. So that has become elevated. It's something that we are looking out for. In terms of falsification of treatment records to justify payments, again, I have seen those. Sadly, in the last couple of 2 or 3 months, I've even seen claim forms being amended in terms of the diagnosis. So, for example, if the diagnosis was gastritis, and you'll find somebody has added a stroke, H. pylori, a stroke, something else, and then with that diagnosis, the prescription is amended, and then the billing that comes to the insurance company is exaggerated. I've seen misrepresenting of diagnosis, especially during COVID times. A lot of COVID cases were not covered because at that particular point, we did not have a COVID cover. But then what used to happen is that somebody would go in with a COVID diagnosis, but then that COVID diagnosis is not called COVID, it's called something else for it to be able to fit into the scope of cover for an insurance company to make payments. Forgery of prescription, diversion of prescription, this happens both from a provider end and also from a patient perspective, especially when we run out of some certain medications. medications like HIV medication. When KEMSA doesn't have these drugs and people are not able to get the ARVs, then what you get to see is medication like, I think we call it a tripler. You'll find the consumption goes high. And then you start asking, in my population, how many HIV patients do I have? Then before you know it is that somebody with a medical card has colluded with somebody else. They have looked for a fake prescription, they've looked for a fake claim form, and they pick the medication. I'll not go into double billing, that is straightforward. Billing for more expensive services, again, we've seen, especially for specialized care, that coming in. Impersonation has been on the rise with all the challenges on NHIF, for example, or where you have sick relatives and they're not on cover. We've also seen some certain regions in the country. This is more prevalent in some certain regions where somebody goes in, for example, I've seen somebody with 2 wives and cover only allows 1 wife. So in one case, you go, you tell the provider, I'm here with wife A, but when wife B becomes sick, then you go and say, biometrics are not working. Can we change the biometrics? Then when you get the claim documentation, you realize wife 1 was 40 years, but now you're dealing with a 25-year-old. Then you're asking, what is happening? Forgery, I will not go into it. And then we've got what we call doctor shopping, where, person visits multiple providers to get prescription, especially for controlled medication. We've seen this for hypertension drugs, diabetes drugs. I think people are just moving around collecting this medication. So I'll not go into the other slides. If time allows, I can show you a few examples, a few of these things that I've mentioned. I can show you, but this is just to set the stage for us and to give you an idea of what we see from a provider perspective. Thank you.
Thanks a lot, Jack. That's been pretty insightful. I'm sure we probably have a number of questions, but I wanted to check with Liz. Liz, are you back online?
Yes. Thank you, Dr. Okaka.
Great. So we will have Liz take the next session. Jack, if that's okay, we will have the questions at the end just so that we lump them together. And so I want to hand over to Dr. Elizabeth Gitau, who will introduce herself. But as I said, she's probably no stranger to you, and then to make a presentation. Please, the stage is yours.
All right, thank you so much, Dr. Okaka. My name is Dr. Liz Gitau. I'll just put my video on for a few minutes as I introduce myself. I am the current CEO of Kenya Association of Private Hospitals. So I sit at the Secretariat representing private facilities. And I also sit at KMA as the Assistant SecGen. And part of that also, I've been seconded to the Medical Council to represent KMA. So basically, these issues about fraud, I think we deal with them on a day-to-day basis. So thank you, Okaka and team and the Managed Healthcare Committee for organizing this. Of course, it's a relevant matter in this current industry within the healthcare sector, because it affects service provision and affects both the efficiency and the cost of medical service provision. I'm glad the previous speaker, I think, has gone through the various types of medical fraud that are there. But I'd say in terms of from a provider's perspective, yeah. So from a provider's perspective, I think majority of the providers getting into the industry get in to do a certain job. And most of the time it is to ensure that they offer health services to the communities within which they live with. However, of course, you'd have those ones who collude with other people for them to perpetrate medical fraud. So I'll go through in terms of how does medical fraud affect. I'll not go through the types of medical fraud because that has been covered. I'll go through how does it affect us as providers. One, in terms of increasing the cost of health services, with the increased rejections, both due to the high vigilance of the insurance industry because of the existing fraud, they become sometimes extra vigilant to some of the cases which might not be fraud, but look like fraud. And that is sometimes some of the issues. Like, for instance, I think double billing has been mentioned. Sometimes you're seeing a patient today, you're seeing them tomorrow because of the nature of the illness. However, because that has been misused in the past, you're actually labeled as one of the people who's doing medical fraud through double billing. Again, it affects us as providers because of the inefficiency within which claims are being processed. And this because the insurance industries have had possibly to layer extra processes within their claims processing to ensure that they're not processing fraudulent claims, which increases the time and increases the inefficiency within which your claim process is done. And even the inefficiency of patient care, because some of the verification process for you to know that you're serving the right client sometimes goes way and above the possibly the time that you'd want to take for you to actually serve a patient. So for us, from a provider perspective, it's mostly increasing costs because you have to cover the cost of possible rejections. You also have to cover the cost of extra time taken for your bills to get paid because of the various verification process. Again, medical fraud, I think private facilities have possibly been put on the spotlight in terms of medical fraud because, of course, we're the ones who interact a lot with the insurers, including NHIF. Yeah? And essentially, when there is fraud, as the expert has rightfully said, there has to be collusion, either between the provider and the patient, and the provider and somebody within the insurance industry. From our perspective as providers, I think some of the biggest fraud from our colleagues usually happens in collusion with somebody within the insurance industry. For instance, when you look at NHIF, when there's fraud and money is being paid out, there's always somebody approving your claims faster than other people. There's always somebody who's approving things that you have not done. There's somebody skipping a process for you to get paid. Even when it comes to payment, there's somebody paying you faster than other people. What does that do? It inconveniences the rest of us, because when money is stolen and when you have claims of medical fraud, all of you look, when you're in a place where some of you are doing the wrong thing, it makes all of you look bad. And as it is, when you look at when private facilities are called out for fraud, there is no distinction between Okaka's clinic and Liz's clinic and Kigondo's clinic or whoever else. It is just private facilities, which makes our cost of even aligning our name to our patients become harder, because they're always looking at you as if you're the next fraudulent person. It also makes, like, for instance, NHIF right now have the audacity of not paying you because the thing is medical fraud. When you look at the Insurance Act, it actually stipulates that a payer must pay you within 90 days of you raising that invoice. But you see, sometimes they can use this reconciliation process or checking process or verification process to avoid medical fraud to delay your payment. So those are some of the industry things that actually, as providers, are affecting our business processes because of what some of us are doing. In terms of what we can encourage payers to do is to ensure, even as processes are being put in place to ensure there's no medical fraud, that does not affect significantly the efficiency within which we are able to provide care. Okaka, I don't have much more to add. I'll probably add more during the Q&A.
Thanks a lot, Liz. That's been comprehensive. I already have a number of questions, some even sending me privately. But I wanted us to have Michael. I think we've lost him again. Michael, are you on the call?
I'm here.
Great. So we wanted to speak to someone from our regulator. So Michael sits with the Medical Council, and he'll tell us more about himself and give us his perspective before we start asking the tough questions. Thank you, Liz, and over to you, Michael.
All right. Thank you, Dr. Okaka. Thank you very much. As has been said, my name is Michael Onyango. I serve as the Cooperation Secretary at KMPDC. I'd like to correct, I don't sit at the council. Dr. Liz sits at the council, but I work for the council. So I'm an employee of the council. That being said, I just want to go straight into my very short presentation. I'll skip a few slides because I think a lot has already been captured by Dr. Gitau and by Mr. Jackson. So allow me to just nitpick through my presentation. Medical fraud, I know the main topic that we've spoken about today is medical fraud, but I would just like to paint a picture that there are actually other fraudulent activities that happen within the health sector that are not necessarily medical fraud. And they start from small things like, as a practitioner, forging your logbook details. Did you do the procedures or not? Did you finalize what needed to be done, or did you just fill in the book and try and go and swindle the consultant? When it comes to registration, it's fraudulent for you to bring fake papers that you will now be used as a basis for you to be registered. In terms of licensure, do you have proper professional indemnity? Is it proper, or have you just uploaded PDF documents onto the portal? But there's something now we're working on that as a council to be able to ascertain the PIs that have been uploaded. In terms of your practice, how are you handling your patients? There are now the issues of billing fraud. When you go to the issues of prescription fraud, patient fraud, identity theft, using falsified medical history to gain benefits or services, kickbacks and bribes, receiving and offering legal payments or incentives in exchange for patient referrals or services, unnecessary procedures, which have been spoken about. We at the council, we do have a disciplinary and ethics committee that looks into these matters. Some of these matters have come to the council, and we've been able to pass judgment against some of the practitioners or hospitals that have participated in such fraudulent activity. But on a wider scheme, aside from just the punishing, as has been said by Dr. Liz and Mr. Njuguna, there are far-reaching effects that it has within the healthcare system. By you being fraudulent, it denies somebody else those services or resources that they may need to use to be able to seek healthcare services. In terms of the legal framework, so far, what do we have that deals with medical fraud? I know we usually just see in corruption cases, government officials or high-ranking officials, but even the private sector, even those who are doing their own economic activities, you are under the Kenya Anti-Corruption and Economic Crimes Act. You can be investigated under that act. There's a Health Act, which speaks about issues of billing, issues of health insurance. How do you treat patients in terms of their confidentiality and use of their information for proper use, not for financial gain? The Insurance Act, Mr. Njuguna has spoken a lot on that and touched on the Insurance Act. Right now, the council is working with IRA to be able to address some of these issues that are bedeviling the medical insurance industry. Pharmacy and Poisons Act, in terms of issues regarding prescription fraud and doctor shopping for some substances that are controlled, all those issues. The penal code, fraud is a crime. You can be charged as a criminal under the penal code. Now this is not just a civil matter where it's between you and an insurance company. This is now between you and the state. And you can be able to charge and jailed accordingly for either misrepresenting facts or trying to be fraudulent or forging documents for purposes of gaining financial gain. Now, with regards to proper procedures for reporting suspected fraud, at the moment, we have internal reporting. So we are actually in the process of developing a guideline document for health facilities so that they can be able to put measures, the measures that Dr. Liz Gitao has mentioned that actually cost money, measures that stop, prevent medical fraud, how to report them, and how to deal with them. And in the event that they're not able to deal with them at the hospital level, they can now externally report them to KMPDC to be able to deal with it. So these are issues that there are some matters where hospitals have brought cases before KMPDC to deal with, and they have all the evidence. They bring the evidence before the council, and we're able to adjudicate over the matter and punish the perpetrator accordingly. Those that have an economic crime or criminal angle to it will involve DCI, will involve the Anti-Corruption Commission. In terms of whistleblower protection, as it is right now, mostly under the Bribery Act, that's where issues of whistleblowing are usually dealt with. However, the country is undergoing the process of developing the Whistleblower Protection Act, but now it's still at a bill level, still stagnating as of 2021. We are really hoping that this can go further and become an act of parliament so that institutions are not left to just develop their whistleblower policies, but we can have a national act of parliament that actually guides how whistleblower protection can be done in the country, so that some of these issues of medical fraud can be rooted out, and that those who actually whistleblow don't end up being the victim, and they don't end up being victimized, and that it make people a little bit more bold to be able to come out and call out issues and say, hey, this is not right. I saw this is not okay. Because at the end of the day, they feel protected. They know they will not be victimized. They know they'll not be the target. They know what they are doing is the right thing. Legal obligations regarding reporting fraud. We have the code of conduct, which says, yes, when you see fraud, you are supposed to report it to the council. And because those who actually don't report, that is a breach of professional ethics. But I feel that is like a double-edged sword, because now it makes it's like the scenario of someone who gets hit by a car on the road, and people get afraid of being a good Samaritan because they feel when they take this person to hospital, the police officer will turn on them and tell them, hey, how do we know it's not you who caused the accident? So that's why issues of whistleblower protection are being brought on board to make sure that those who step in to either avert or point out issues do not end up becoming victims. And there are also legal obligations and there are anti-corruption laws. For example, issues of NHIF, there was a whistleblower on that issue. You need to, depending on circumstance, failure to report medical fraud has implications under anti-corruption laws, potentially leading to legal consequences. There are instances where employment contracts between an employer and an employee, you are given a contractual obligation that you need to report fraud. If you do not, you stand the risk of losing your job or being terminated for such issues. Criminal liability, depending on the nature and extent of the medical fraud, there may be civil or criminal liabilities associated with not reporting it. So there's a responsibility placed upon you to be able to report this. And we at the council, what we have done, we have created an avenue where you can report anonymously. You can come, you drop something in a box, there's an email, you don't have to say, you can even use a blind email. You open an account, send an email, give us information, and there are certain circumstances where we've picked up information anonymously. When we did our investigations, we found the issues to be true, and we did take the necessary action. And last but not least, just to wrap this up, there are ethical implications to medical fraud, because at the end of the day, there's a Hippocratic oath that doctors did take, that you will do no harm and that you will not be guided by anything else, but by trying to make sure that the patient gets the best healthcare possible. So you need to be able to maintain that patient trust. Being fraudulent destroys that trust, and that now puts you at loggerheads with Act and the legal provisions that are in the Acts of Parliament in the country. Upholding professional integrity, there's certain behavior that is unbecoming of a professional who is a doctor. So if you're fraudulent, you can be held against that standard, that activity is unbecoming of a doctor of good standing. And that's in the code of conduct, and you can be held to account on those grounds. And that considering the impact on public perception to preserve the reputation of healthcare sector, that's something that we're struggling with. I'm sure something that has been mentioned with regards to the recent cases of NHIF, which we're trying to deal with. How can we move forward as a country and deal with the issues of medical fraud that do not drain the resources that are needed to treat Wanjiku? I think that's my baseline of the legal and ethical issues surrounding medical fraud, but I think we can be able to touch on more issues during Q&A. Thank you.
Thank you so much for that, Michael. That's been pretty insightful. And I guess then we could start the Q&A. And before we start looking at what is in the Q&A section, I have a question to Jack. As you were speaking, I decided to check on the IRA statistics on medical insurance fraud. And I found something pretty interesting that so I was just looking at the last few years, from 2016, the number of cases of medical fraud reported annually, at least to the IRA. So in 2016, we had 7 cases, then 6, then 5, then 9, then 12, then 11 in 2021. And 2022, we had 0 cases of medical fraud reported to IRA. We don't have 2023 data out yet. But Jack, what do you think is happening? I mean, you guys are saying there's a lot of fraud. IRA seems not to be reporting many cases. What's the disconnect? What are we missing?
Interesting question that time. What you're missing is, I would sum it by saying, is a question of trust. Unfortunately, what has been happening is that there has been minimal collaboration between the office that is mandated to tackle these cases at IRA, that is the Insurance Fraud Investigation Unit, with the players in the industry. So what has been there, the challenges that have been there are the usual challenges that we would know with our law enforcement. And this is unfortunate to mention that, cases would go there and cases will either not investigated in good time or investigated, not concluded, and so on and so forth. So then what that did over time is that players in the industry started holding back in terms of reporting information. And what we started seeing, which you will not see being reported, is that people went either through civil remedies, where you can prove your case, then you go for that particular provider or person from a civil perspective. And in some cases, I've also seen where people sit down and get an out of law enforcement, out of court sort of an agreement to recover the lost funds. Now, interestingly, I hope once you see the 2023 statistics, you'll probably see a different picture. We've had some changes at the Insurance Fraud Investigation Unit. I can tell you that we have many more cases in 2023 and 2024 that are being handled by that particular office, and probably the statistics will change, but it's just a question of trust that has not been there between the industry players and the office that has been mandated to look after fraud from a criminal perspective.
Thanks for that insight. First, let me welcome Dr. Tim Theuri, who's just joined us. Tim, you'll have a chance to give your comments. Tim is the CEO of KHF, our partners for the webinar today. But Liz had mentioned she had a comment. Liz, what do you think? What's happening to this IRA statistics. What are your thoughts as hospitals?
Okay, go ahead.
Go on,
Okaka?
Liz.
All right. Thank you, Okaka, and I'm glad you've mentioned IRA. So on behalf of KMA, I accompanied the chair of KMPDC to meet the IRA chair. And some of the things that we addressed in that meeting, or from our side, that we felt that IRA might not be well prepared in terms of to deal with medical insurance, in terms of oversighting, and even in terms of the processes. Remember, I think according to the insurance, I think health is also classified as general insurance, which sometimes does not take care of the unique nature within which medical industry occurs. Medical insurance companies have resorted to taking care of the fraud issues internally, such that they either reject a bill if they think it might be fraudulent, or, for instance, sort of disempanel a doctor or a medical institution when they feel like there's some fraud that might be there, without taking the longer route of legal aspects. So one thing we asked from IRA is that they might want to create a healthcare desk within the IRA, so that it can be able to understand significantly the medical insurance aspect from a health industry perspective, and also the uniqueness that the claims are significant in terms of their numbers. Yes, we might have a very small population of Kenyans insured, but when you look at the percentage of claims that are done per day, are quite significant compared to other businesses. So for my end, I think there's a lot of strengthening of IRA that needs to be done for you to now have an opportunity to be able to report the same.
Thanks for that. That's probably something that should have happened long ago. And it's insightful to hear that IRA maybe hadn't thought of that. So a number of questions are coming through in both the chat and the Q&A tab. I'll just go through one by one and we see who can tackle which one. A question from Abdi Greek, who asks about those who make false medical diagnosis and then claim undue benefit. Anything medical regulators are doing about this? So false diagnosis. I guess that's to you, Michael.
Yes, thank you, Kaka. Thank you for the question. I think that question is from Abdi Greek. Okay. So I think with regards to professional regulation on this particular matter, I can speak towards how KMPDC has handled on matters from medical and dental practitioners, because those are the practitioners that are within our jurisdiction. The pharmacists are probably are under the Pharmacy and Poisons Council and Poisons Board, clinical officers council, nursing and so on and so forth. So to speak with regards to issues of medical fraud within the council, Kenya Medical Practitioners and Dentist Council, we actually stand at financial issues, stands at number 5 in terms of the number of cases ever lodged, in terms of the proportion of cases. At the top is obstetric, gynecology, surgery, internal med, pediatrics, and then number 5 comes financial issues. And we have sanctions which we met out against practitioners who are found out to have engaged in medical fraud. The issue is with regards to finding the evidence, especially when there's collusion with the hospital. That becomes a bit difficult for us. And in that instance, now we refer it to the DCI or EACC for handling. So that will not be factored in within our numbers, because now that is being handled by another authority. But within KMPDC, with regards to medical practitioners and dentists, a case is brought before us with sufficient evidence, we will make the decision and punish accordingly. If there's no issue, we acquit. Thank you.
Thanks. That's again insightful. Another question. This is mainly say to Jack. maybe let's answer the two questions together. How you differentiate, you mentioned invoice splitting. Is there a way to differentiate it from bill itemization? And then is there any way you as insurers can prevent unnecessary procedures?
Okay, thank you for the question. So in terms of the differentiation between invoice splitting and itemization of a bill, when you itemize a bill, the provider only gets one invoice for one patient for a certain treatment, and then the bill is broken down. When you split an invoice, you will get different invoices for the same patient, either on the same day or over a period of 1 or 2 days. I wanted to quickly show you an example, very quickly. I trust you can see my screen. This is just a summary
yes, I can.
to show you. Yeah. So
Okay.
what you're seeing here, I've redacted some information, but what you're seeing on the screen is basically two patients who have been seen. So if we walk through the first case very quickly, you will see like in the month of January in 2024, this person has been seen on 4 different occasions. If you look at the invoice items, you'll see they are more or less the same. You'll see they are more or less the same treatment. Now, what you cannot see here is that this person was actually visiting the same provider, but either different branches. In 1 or 2 cases, he visited a different provider. Now, if you go check his history in December of 2023, again, he visited 4 times. Now, if you look at what was invoiced, what was diagnosed, and of course, the medication that was given, there is no way that this person had exhausted even the first medication or the first dosage before he gets the second. So in this case, then you'll find that this particular provider, and as I mentioned, some of these were on the same provider, but different branches. So we get different invoices for each of these. And you will see in some cases, for example, on the 5th of January, this person went or got 2 different types of medication, same kind of diagnosis, but we get 2 different invoices. Same case down here. Again, this is one person, same provider, different branches. In some cases, 1 or 2 different providers. If you just look at the number of visits that this particular person has made to different doctors, if you look at the dosage that was given, if you look at the diagnosis, there's something that is off with this. So this is what we call as invoice splitting. So I hope that answers your question. In terms of what can insurers do to avoid unnecessary, go to the question, unnecessary procedures. Yeah. So one of the things we have done is to come up with what we call a fixed cost sort of an arrangement with providers, which I know we also get a bit of backlash on it. But the reason why we've done this is to give you an amount of money, and then we say, fix everything that you want to do on this patient on this amount. And some providers will go and say, okay, we don't need to send this person to the lab, therefore that is avoided. Another person will say, this person requires to go to the lab, therefore you send to the lab. At the end of the day, the way we look at it from a provider perspective is to say, for example, if we have agreed that our fixed cost is 4,500, there are patients who only need a consultation, which will be, let's say, 1,000. But there's a patient who will need much more than 4,500. At the end of the day, as the underwriters will still pay you 4,500, even if you only incur 1,000. So at the end of the day, it's a win-win, but it forces you as the provider to fit within a certain scope of treatment and not to deny the patients the care that they deserve, but also not to call for unnecessary or procedures that are not warranted. The other thing that we are trying to do is to come up with treatment formulary where we define all manner of diagnosis and what does it take, so that then we come to providers, and these will come in the fullness of time. We come to a provider and we say, if the diagnosis, for example, is gastritis, and the patient is of a certain age, the patient is exhibiting symptoms 1, 2, and 3, this is how this patient is treated, and this is the cost of treating this particular patient. So then that way you are able to fit within that. Now, of course, that has not been able, we've not had very good traction on it, because again, there has been differences in opinion, differences in treatments, approaches, and so on and so forth. But in the fullness of time, we are getting there. Now, what I also need to mention as the last point that insurance companies are doing, artificial intelligence is here with us. And in the fullness of time, there will be systems, and they are already being tested, where if you come in and you say the diagnosis was, let's say, H. pylori, and you treated the patient and you gave a certain medication and you gave some certain lab request, AI will pick that bill using its logic, will actually highlight to the underwriter, with this diagnosis, this medication is acceptable, but this procedure is not acceptable. And those will now start being declined, not by human beings, but by systems that are learning. In fact, there are very good systems out there. Some of them have been piloted in the country. I know one that is already in the country, and some underwriters are using it. Internally, where I work, I also know we have some 2 systems actually that look at these particular claims and they stop them. Now, over time, what has happened is that because of the rejection of some of these procedures, then it forces the providers to do the right thing. And that's what we are all aiming to make sure that unnecessary procedures are being avoided. I hope those answers your question.
Yes, this answer many of the questions. I'd like to take the next set just because we're almost getting short on time. There's a question from Jackson Juguna with regards to, so insurance is interfering, quote unquote, with care. Say in this, described a case where they called a patient of his or of theirs, right? Who has already, you've been seen by Dr. A, you've been seen by Dr. A, you move to doctor, the insurance calls you and tells you, you can go to this doctor and who will be cheaper. Or one case that was sent to me actually by SMS just now is a similar case where the insurance declined what a doctor thought was a necessary admission. So they declined the authorization or admission, and the patient complicated. The question I have, and Jack, I hope you're wearing your helmet, is how then do we handle instances where as a payer, because you think you're either reducing cost or trying to avoid fraud, quote unquote, then you interfere with the duty of care to the patient, and for lack of a better term, how can that be handled in your perspective, Jack? And is there a legal way to also tackle it to you, Michael? Where is there something we can do about it from a legal standpoint?
Wow,
so Jack first, then Michael.
That's a tough one. I'll try and answer it from a provider perspective. Now, in most cases, from what I have seen, where an insurance company either contacts the client or quote unquote interferes with what the doctors have said, it boils down to an element of cost. And it also boils down to the availability of the doctor to perform the procedure in a facility where we have negotiated for a better price. And you will find, for example, somebody wants the procedure to be done at, let's say, MP Shah, but then we come and say, no, we have negotiated for a better deal at Nairobi Hospital, but then the doctor says they don't have admission rights there, I cannot use that facility. Then it becomes a bit of a pull and push. Now, unfortunately, in some cases, it has ended up that the primary doctor treatment was not followed when the patient was taken to or diverted, quote unquote, to the other provider. Now, is it legal, illegal? it's a yes and a no. Yes, in the sense that somebody may argue that the patient was denied the care that they deserve. And no, because somebody will say the same service is available at an affordable price, and at the end of the day, we want to give a customer good care, but at a considerable pricing. So from where we sit, unless it is a matter that is really, we have totally failed to agree. What we try and do first is to negotiate with the primary doctor. If we say, for example, and I know the teams that do this are very open, they will say facility X is charging, X amount. Are you willing to match? If the doctor says no, then as the underwriter, you are left with no option, because at the end of the day, you also want to save the patient some part of that cost. So, Dr. Long and short of it, as an underwriter, at the end of the day, I know those decisions are cost driven. I think as an industry, as all stakeholders, we need to agree, because what we see again is, the variation in prices, and I understand facilities are different, cost will be different, and so on and so forth. But there's some prices that come on the table, and you are left with no option other than to move the plans to a different facility.
Jack, do you have any comments on that? What are the legalities around it, especially if you could address it from the aspect of duty of care? Because then there is someone who maybe the interference also leads to either a complication or an admission that was unnecessary, or harm, or even loss of life. I'm sure that is possible. Jack?
Michael, actually, Michael.
Sorry, Michael.
Yes.
I've been with Jack too much.
It's okay. Now, I'll anchor off from what Jack said, and it's a yes and no, because from my standpoint, it's not necessarily entirely a legal issue. It's a policy issue. It's a policy issue that has failed the practitioner and has failed the patient, where health service delivery is not synergized with healthcare financing. And it is what has now born the ideology of commercialization of healthcare delivery. And this is now where all these issues come in about this. It's cheaper here. I don't have admission rights there. In my view, it's a failure of the policy structure of how healthcare, maybe I'd say how UHC should be delivered, where those who provide, there's no synergy between healthcare service delivery and healthcare financing. But with regards to what you said on duty of care, a practitioner has a duty of care to the patient. Now, the practitioner is dealing with the patient care aspect. That is their primary concern, not the payment aspect. So, in my view, the practitioner should ideally focus on providing health services, but be able to have a conversation where they agree and tell them beforehand that these are the circumstances. This is what I as a patient can afford. This is what my insurance scheme allows me to do. And as a doctor, you can be able to either agree to that, or you say, you know what, I'm not able to be able to go towards that, and I will not be able to give you the proper patient care if those are the restrictions that are being bestowed upon me to give you the care. So that's just to answer that question specifically. But countrywide, nationwide, I feel it's more of a failure of policy with regards to healthcare service provision vis-a-vis healthcare financing.
Okay, thanks a lot.
Maybe Dr. I can add one thing just before we move away from
Yes.
that question.
Yes, please.
Yeah, because I saw somebody in the chat asked, do these insurance companies have medical professionals? The answer is yes. We do have doctors within the companies. For us, even to make a decision to either move a patient or transfer a patient, it's a clinical decision. It's actually not an insurance decision. It's a clinical decision that is reviewed by an in-house doctor and the treating doctor. And if the two cannot agree, then at that point, that's when a decision to move the patient is actually made. Thank you.
Okay, I will want to steer the discussion away from that because that also has the capability to be a hot topic. But somebody asked an interesting question, and I think this would probably be relevant. Back to you, Jack. You mentioned, give examples of fraud, insurance fraud, from the provider and doctor perspective. Somebody asked, are there examples of either fraud or malpractice from the insurer side? And do you have any examples? What would that look like? Or is it only instigated from the provider and from the patients?
At the moment, I don't have any example of a fraud from the insurer side. What I have seen that is a bit of a context between the insurer and the provider is when either there is rejection of a bill, partially or in total. And then the provider will come and say, you're not ready to settle my bills, and you're using flimsy reasons to reject the bill. I've also seen where they say there are delays in payment of dues that are either to providers or individual doctors. Those are the kind of largely complaints that I have seen coming from the providers to the insurer. I'm yet to see an outright case where a provider has committed, an insurer has committed fraud against a provider other than those that I have mentioned.
Okay, thanks for that. The other question that then I would like to ask as we sort of start thinking of winding up, how does one report suspected fraud? What are the places one, if I'm a provider, the guys who are listening on the call, I think there's some fraud here. Who do I report to? How do I follow up? Jack and Michael.
I'll go first. That's fairly simple. You can report to KMPDC. You can report if it's an NHIF issue or now the upcoming SHA. You can report to them. EACC, DCI. But because you're practitioners and you have a regulator, you can report to us. You can either come to us openly or even anonymously, and we can be able to provide the necessary avenues for you to report issues anonymously. So that's to answer that question long and short. I guess with regards to insurance related fraud, we go to the IRA, but maybe Jack can speak more towards that.
From an insurance,
yeah, Jack, go on.
Yeah, so from an insurance perspective, there are a number of ways. One is that you can go to the IRA websites. They do have a page or a portal within their website where you can raise a complaint or a fraud issue. You can also report to them anonymously. You can also report to AKI, that's the Association of Kenya Insurance, where we have an umbrella body that can escalate the issue to the insurance fraud unit. You can also directly walk into the insurance fraud unit. They are located at Shelter Africa, or even email them. They would be able to respond. And as I said, in the last couple of 1 or 2 years, we've really seen some good and commendable work coming from that particular office. For us in particular, at Jubilee, where I work, we have a number of ways. One, anonymously. If you go to our website, you'll find our type of anonymous email address that you can use. Secondly, we do have a dedicated email for that, which is reportfraud@jubileeinsurance.com, and report to that, and the matters will be picked up. And of course, we are available. You can always reach out to us if you have any suspected fraud through email, through phone calls. We'll be sharing our contacts, and we'll be happy to assist.
Thank you so much. Liz, you've been quite silent. I don't know whether you have any comments on the questions we've asked so far. Liz? I guess we, yeah, maybe she's unable to speak. Someone has raised.
Okaka, apologies.
Yes, go on.
I think I was just going to make a comment in terms of the direction within which the issue of medical fraud and cost has propelled the practice of medicine. And I've even stated in the comment that professional associations now have a duty to actually support development and dissemination and approval of guidelines which shall be used all industry-wide, so that insurance companies are guided by the same, because the moment the insurance company, which is the one which is directing medicine, it becomes a sort of like a dangerous ground within which to practice medicine. And then, for instance, if you're in terms of costing, I know we have done the KMPDC guidelines, but again, I think industry-wide, majority of either the payers, whether it's NHIF or any other, do not adhere to the KMPDC laid out guidelines. So at what point do you decide what something costs, so that at some point when you're transferring one patient to another, you're not having a situation where a patient is getting either lower care from maybe a facility without the right equipment or adequate equipment or adequate expertise, because possibly it costs cheaper. So I think this is a time probably the association need to work hand in hand with the payers to be able to develop guidelines within which people to work, so that also it's also fair for the providers, because as it is right now, providers sometimes are confused with the many processes. For instance, there's this payer who uses this system to do what, just to curb medical fraud or something, or this other payer who pays this amount, this other payer who wants the invoice in a certain way, so that you can have a standardized way which is able to serve all parties, is able to be traceable and trackable and accountable to everyone.
Thank you, Liz. As we wind up, I don't know if you're seeing a common thread among the questions, and it boils into what Jack had presented as part of perceptions on fraud. We've had an industry that unfortunately now has been shaped by perceptions on both sides, where the payers have this perception that the providers have an incentive to steal, and so then put in place so many things, even what we call cost cutting, measures here and there, you're all in a bid to also curb fraud. And on the other side, there's also the perception from providers that payers just want to cut costs and just want to save money, etc., etc. And so to Jack again, knowing that we have built a system around fear, as you say, I know you spoke to greed, so we were worried about greed, but then we built a fearful system, and it's shaping all these other questions that people are asking. You've seen all the questions in the chat and the Q&A. How do we, in your opinion now, where do we start from? Because it seems that we will probably not see eye to eye, currently, but where do we start from in mending this system we are in, to then ensure that on your side, you're also not lumping everyone together, and on the provider side, they're also not lumping all payers as, those people just want to cut costs. Sort of esoteric question, but any thoughts?
It's a good question and a timely question. In my view, we need to go back to the basics, and the basic is a question of trust. That as an insurer, I'll trust you as a doctor to do the right thing for the patient. And you, as the provider, as a doctor, you will trust that the insurance company will fulfill its obligation, without delays, without dangerous cards under the table. Why do I say this? If you look at it, at the end of the day, businesses are to make money, but the monies that are to be made have to be made in a legit way, following the due procedures that have been laid. Unfortunately, what we have seen is an attempt to profit where either the doctor or the provider does not deserve to be paid whatever it is that they are asking. And that's why I think if you ask those of us who sit in the insurance industry, will perceive most providers, most doctors, people will say they are trying to profit from things that are exaggerated. And I know it's a hot debate, because what is right when the doctor is sitting with the patient, in terms of the doctor is the one seeing the patient, the doctor is the one prescribing, the doctor is the one diagnosing, and so on and so forth. And the insurance company then sitting without the benefit of seeing the patient. What kind of right do they have to question the doctor? But at the end of the day, we all must agree that something is not right. And what is not right is, one, are we giving the best care that we should give to these particular patients, or are we financially driven? I want to pose a challenge. It's one, there is the regulator who needs to go and check, one, are the providers doing what they say they will do? Do they have the facilities that they say they have? So that tomorrow, when I send a patient, let's say it's to a level 4, a level 3, a level 5, as an underwriter, we expect a certain standard of care, a certain standard in terms of equipment, and so on and so forth. But what we have seen again is that you will hear it's a level 4, but when you walk in there, it is not a level 4. Then two, we have costs that in the current circumstances are not making sense. And why are they not making sense? Is because a simple thing as a common cold comes accompanied with a lab test. And we're not saying it is wrong. The lab test may have been valid, but we need to go back and ask the question, was it necessary? Is it justifiable? Or was it financially driven? All of us, because we are all interested stakeholders in this, we all need to agree that things have not been going ahead. And at the end of the day, we all need to survive somehow in whatever manner, form, or format. But the path that we have taken, which is largely profit-driven, largely financial-driven, is not working for us. I have sat in companies, for example, in some pharmaceuticals, some local manufacturers, and I have said, guys, can you agree with us that if the diagnosis is X, give us a treatment formulary, give us a fixed price. Then tomorrow, when we go to the market to sell a medical product, we'll be telling the person, when you sign up for this particular medical product, this will be the price that you pay in terms of premium. This is how you'll be treated. These are the facilities that will treat you. In 3 or 4 big pharmacies that we have visited in the country, they've always said no. Reason being, they do not have control of the prescription that the doctors will give. And therefore, this battle goes back to the doctors. As doctors, we all need to sit down and agree that something is not right. Something has gone wrong. And what is this? in my view, a lot of it is just the profit motive. In the commercial side, we say, profit with purpose. I think we have, that has been forgotten. We are now doing profit for commercial reasons, and we really need to go back and say something has to stop as doctors. And then when we agree that this is the way forward, then all stakeholders will be willing to work with you. And unfortunately, as I've given that example of what we try to do with the pharmacies, at the end of the day, when that question is asked, we all go back and say, but the doctors have the control of the patient. The doctors have control of the prescription. The doctors have control of the lab request that this person will be given. And because of that, I, as the underwriter, I don't have control over my costs because a lot of it is controlled by the doctor. The pharmacy doesn't have control because it depends on what the doctor will say. The lab doesn't have control because, again, it's what the doctor will say. So at the end of the day, as doctors, we need to call ourselves for a meeting and ask what has gone wrong. Thank you. I hope I'll not be stoned.
Yeah, no, it's good you are opening the door for us to start having these discussions. Liz, can you give maybe your final comments? Where do we start as a provider? Where do we do this? And then we'll have Michael giving us a comment.
Thank you, Park. I think from my end, I had alluded to it. When it comes to medical practice and clinical practice, I think at some point we might want to agree on standards of practice, which are adopted by the various professionals. And I think the professional association, especially being led by KMA, and now looping on board other professional association, provides the updated professional guidelines for treatment of various conditions so that these are adopted by various payers, so that it is very clear what you do for what and what is payable for what, so that you're not getting into a situation where each insurance company sort of have their own guidelines, which is advised by their experience with providers. So I think from a provider perspective is one, to have guidelines, and also in terms of having continuous engagement to be able to understand these issues so that we can be able to understand each other, the payer to be able to understand the provider, and also the provider to understand the payer's perspective, so that we can get a better way forward and create some levels of trust. And overarchingly, I think through AKI and IRA, we have possibility of providing more oversight to the medical and the health sector, so that we curb fraud. And finally, of course, also the regulators come on board in terms of ensuring our professional code of conduct is followed for professionals. And KMPDC is also in the process of developing ethical guidelines for healthcare facilities, which will also guide in terms of how does a facility act in the proper manner. Thank you.
Thanks a lot. Michael? Hello, Michael, are you with us? If he's not able to speak, then that will be it. Thank you again to the speakers today. I know this is a hot topic, and I know we would probably not even touch the tip of the iceberg if we start opening up. But thank you again for your insights. Special thanks to Kenya Healthcare Federation. I don't know if Tim is on the call and is able to speak, our partner. If not, that's still fine. So Kenya Healthcare Federation has been our partner for this. We have just one announcement, that then we are inviting you all to the Kenya Medical Association Scientific Congress. KMA is putting it up. Yes, so we have our 51st annual scientific congress to Kisumu at the end of April, so 21st to the 24th to the 27th of April. You're welcome, and you can find the details to register as shown on the KMA website, so kma.co.ke/KMA Congress /KMA Conference, and that's the charges for the same. Thank you again so much. Buona President, maybe you can help us close the session. Dr. Kigondu? Are you back?
Thank you very much, Dr. Okaka. And I don't think thank you very much, Okaka. I don't think there is much to add. I think it was an excellent presentation, and we'll be giving more of these topics in the days going by. I want to thank the Kenya Healthcare Federation, of whom we are members, for facilitating this topic. And I think the discussion cannot be exhausted enough. This is the first of a series of 4 that we will be inviting all of you to. And once again, I reiterate, I also welcome you to the KMA Annual Scientific Conference on April 24th to 27th in Kisumu City, Dala. Thank you very much.
Thank you again, everyone, and have a great evening.